Hi everyone, welcome back to Game Pharmacology. In this session, let us learn about uh, general pharmacology quick revision. Myself, Dr. Padmanabha, TS, Pharmacology faculty at Global Academy of Medical Education. So, welcome to Game Pharmacology. So, we will only see the very important topic that have been already asked in your exams and some of the questions you can expect in the forthcoming exams. So, coming to the first one. So, all of you should remember that who is the Ramnath Chopra. So, Ramnath Chopra was the father of father of Indian pharmacology. So, please remember the Ramnath Chopra is the father of Indian pharmacology. So, coming to the clinical trials. Whenever you conduct a clinical trials, the clinical trial has to be in the guidelines of Schedule Y. So, they need to follow the guidelines of the Schedule Y. So, please remember this can be a potential MCQ. So, what is the schedule which is followed during the clinical trial? It is Schedule Y of the drugs and cosmetic rules. So, next coming to the phase 0. So phase 0 has been asked many times in your exam. Phase 0 is also called as micro dosing study. It's also called as micro dosing study, where it will be taken just before the start of the phase 1 trial. So if this study gets rejected, so what will happen? They're going to decrease the cost that will be given for further clinical trials. So you can cut down the economical burden which you are going to spend on the candidate molecule. So many candidate drugs fails due to suboptimal human pharmacokinetic parameters. So basically here you are going to take the very low dose, that is 1 by 100, the estimated human dose, or a maximum of 100 micrograms, and it will be tested on the healthy volunteers. So we're going to check for the pharmacokinetic parameters. So if the pharmacokinetic parameters are favorable for the testing, so same candidate molecules will be taken further for phase 1 trial. So if in this study, that is in the phase 0, if the candidate molecule fails to provide a beneficial response, then the candidate molecule will be halted there itself and will not be taken for further phase 1 trials, because unnecessarily there will be wastage of the human resources as well as the economical part. So next, coming to the phase 1, phase 2, phase 3 and phase 4 trials. So please remember in your exam, this is very important. So you should remember. So phase 1 is also called as human pharmacology, and it mainly helps in the estimation of the safety of the drug, and it is conducted in the healthy volunteers. Only in case of cancerous conditions you will take the patient. Otherwise, the phase 1 is conducted in the healthy human volunteers, and there will be around 20 to 80 healthy volunteers, and it's an open label study. Basically, you do this study to check the safety, tolerability, and any potential adverse drug reactions and the dose ranging. So following that, once the phase 1 is cleared, it will be taken for phase 2. Phase 2, it is also called as therapeutic exploratory study or dose ranging study. In case of phase 2, you're going to check the what is the normal dose or the dose range or the ceiling limit of the dose which is required in case of the patient. So in phase 2, you're going to introduce the patient. So the patient first comes into the picture in the phase 2. So there will be around 100 to 500 patient. It is an open or blinded study, and it is a randomized control trial. Basically, we are going to determine the therapeutic efficacy, dose ranging, and the ceiling effect, and this will be done in the single centers. So once the phase 2 is cleared, phase 3 is taken up. So what will you do in phase 3? Phase 3 is also called as, please remember, therapeutic confirmatory study or comparison among the larger population, larger patient groups. It will be around 500 to it is 3000, 500 to 3000. So basically it is a randomized control trial where it is a double blinded study, and it will be done at a wider scale to assess the safety and tolerability, and indications will be finalized, and this will be done at the many centers. Then comes the post-marketing surveillance, that is also called as the phase 4. So phase 4 is also called as pharmacovigilance, where you're going to test the same drug in the larger population. So because all this drug tests will be done in the controlled environment in a limited number of candidates, as that is the healthy volunteers and the patient, so we'll not come to know the overall picture of how the drug will going to produce its effects on the larger population. So when it introduced into the market, so we're going to collect the information from the population. So what are the information you get? It is called as the phase 4 or the post-marketing surveillance, where you will be able to find out the efficacy, acceptability and adverse effects. If there were any uncommon adverse effects or idiosyncratic reactions or the unsuspected drug interactions or any additional indications which were not seen during the clinical trial, if they got to notice these findings, they're going to notify to the respective bodies. So basically this will be a major a phase where you're going to check for any drug interactions or adverse effects or any newer indication, in also in case of children or elderly, in pregnant and lactation, and the individuals who are having kidney and liver diseases. So apart from that, you should also remember, when will you take for investigational new drug application. So investigational new drug application, please remember, investigational new drug application is applied before phase 1. So before phase 1 you will apply it. So once you get a clearance of the IND, you're going to start the phase 1. It is IND is before phase 1. So when do you apply for new drug application, that is NDA? So once you clear the phase 3, before going to the phase 4, you are going to apply for the NDA, that is new drug application. So once the NDA is approved, the drug will be marketed in the phase 4. The same thing, the IND means investigational new drug application is mainly before which phase? Before it is phase 1, before phase 1. So when do you apply for new drug application? New drug application will be just before phase 4, or you can also tell as after phase 3. And there is one more phase of clinical trial, that is phase 5. It is also called as pharmacoepidemiology. Pharmacoepidemiology is called as the phase 5. Pharmacoepidemiology is called as the phase 5 clinical trial. Phase 4 will be a post-marketing surveillance. Next, coming to the very important topic that has been asked. So which route has got 100% bioavailability? Which route has got 100% bioavailability? That is your intravenous route has got 100% bioavailability. So how do you define bioavailability into? It is the fraction of the drug. So please remember, it is a fraction of the drug that reaches the systemic circulation, in an unchanged form. So basically this word has to be there. So it is a fraction of the drug which is administered through any route that reaches the systemic circulation in an unchanged form. So it is represented as the word fraction means F. Bioavailability is given a word that is F as a symbol. So what does the area under the curve indicate? So area under the curve indicates the extent of the drug absorption. Mainly it tells you about the extent of drug absorption. So please remember, it tells you about the extent of drug absorption. So what does Tmax tells about? Tmax will tell you about the rate of drug absorption. It will tell you about the rate of drug absorption. There is one more word that is called as Cmax. Cmax will tell you about the maximum peak or the maximum peak or the maximum concentration that is attained at the Tmax level. So next, moving on to the very important topic that has been asked many times in your exam, that is a physiological antagonist. So physiological antagonist is also called as functional. It is also called as functional antagonism. So here the examples will be your very important examples, that is the insulin and the glucagon. And one more example will be your histamine and the adrenaline. So basically what the insulin does is that decreases the blood glucose level. On the other hand, glucagon will going to increase the glucose level. So histamine will cause bronchoconstriction, whereas adrenaline will going to cause bronchodilation. So what are the feature you observed from this example? So there are two drugs which acts on the same system. Basically, they act on a different receptor present in the same system, and it will going to produce the opposite responses. It is called as physiological antagonism or the functional antagonism. So next, coming to the bronchodilator action. So in the bronchodilator, you have got two drugs mainly basically. So you have got the short acting bronchodilators. The example is your salbutamol. Is the shortest acting bronchodilator, and longest will be your salmeterol. So next, coming to the peakless insulin. Peakless insulin means so there won't be any significant sudden surge in the insulin levels in the body when you give this insulin analogs. So these are called as peakless insulin. They are also called as longer acting insulin. Preparation. So D stands for D-dimer, D-gludac, and it is the ultra lente, and the glargine. So basically you have 4 drugs which falls under the peakless insulin. So they are called as D-dimer, D-gludac, ultra lente, and glargine. It somewhere act above 24 hours, and the longest acting will be D-gludac. It will act for nearly 40 hours. So you should remember, very important, 40 hours. So this is the example you should remember. So next, coming to the anti-epileptic, which has got the highest teratogenic effect. So please remember, the anti-epileptic which has got highest teratogenic effect will be your sodium valproate. So it is your sodium valproate. Mainly it causes the spina bifida. Among the anti-epileptic drug, the most teratogenic is the sodium valproate. Even the phenytoin and carbamazepine will going to cause teratogenic effect or the fetal malformation, but the significant or the marked teratogenic effect will be seen with the sodium valproate. Very important. So next, coming to the drug of choice in the cardiogenic shock. So what is the drug of choice in the cardiogenic shock? Drug of choice in cardiogenic shock is your dopamine. So it has got the 3 dose dependent actions which you need to remember. So one is at the low dose, at the moderate dose, and at the high dose. At the low dose, it will act around 1 to 2 micrograms per kg per minute, and moderate dose means 2 to 10, and high dose means more than 10. At the low dose, you should need to remember this will going to act on the specific receptors. So this I have got a receptor selectivity that you need to remember. So the low dose, the dopamine will going to selectively bind to the D1 receptors, which is present on the renal blood vessels as well as the splanchnic blood vessels, and which is responsible for renal vasodilation. So especially renal vasodilation. At the moderate dose, along with D1, it also going to act on the beta 1 receptors, and they are going to increase the cardiac contractility and the heart rate. At the higher doses, that is more than 10 microgram per kg per minute, apart from D1 as well as beta 1, it will also act on the alpha 1, which will going to cause vasoconstriction. So it is not favorable in case of a cardiogenic shock. So only the low to moderate dose is preferred in the cardiogenic shock, and especially the dopamine is preferred in case of cardiogenic shock associated with oliguria. Otherwise, you can go with the dobutamine. Next, coming to the drug of choice in case of the diabetes insipidus, neurogenic diabetes insipidus. So please do not confuse. Please read the questions properly. So there are three important drugs which differs with respect to the diabetes insipidus that you need to remember. So one is in case of the neurogenic diabetes insipidus. The drug of choice will be your desmopressin. Desmopressin is a vasopressin analog. So what is the drug of choice for nephrogenic diabetes insipidus? Here, because of their paradoxical activity, thiazides will be the drug of choice. Although it is a diuretic, because of their paradoxical action, it is preferred in the treatment of nephrogenic diabetes insipidus. So what will be the drug of choice for lithium-induced diabetes insipidus? So please remember, in the lithium-induced diabetes insipidus, so you're going to use one of the potassium-sparing diuretics, that is your amiloride. So basically, it is a potassium-sparing diuretic. Mainly, its mechanism of action will be it block the renal sodium epithelial channels, or it blocks the epithelial renal sodium channels. So next, coming to the grapefruit juice. So whether the grapefruit juice is an enzyme inhibitor or the enzyme inducers. So please remember, the grapefruit juice is an enzyme inhibitor. So next, coming to the therapeutic index. So therapeutic index, how you can remember is TILE. So therapeutic index is a measure of safety, or it is a margin of safety. So they call in terms of many words. It is a measure of safety or margin of safety. It is calculated by the lethal dose 50 by ED 50, that is the effective dose 50. So ED stands for, it is a dose at which the 50% of the individuals will have lethal effect. So LD stands for lethal effect, and ED stands for effective dose. This will be the lethal dose. So therapeutic index is very, very important. So if there is a low therapeutic index, what it does means, low therapeutic index requires a therapeutic drug monitoring, and these low therapeutic index will be more prone for adverse drug reactions as well as the drug interactions. So what do you understand by Schedule H? Schedule H is the criteria that has been laid down by the government. So all the Schedule H drugs should have a prescription, and it should be sold by the retail shop owners, registered retail shop owners, only on production of the prescription. So without prescription, you should not give a Schedule H drugs. So next, coming to the what is the differences between the efficacy and the potency. So please remember, efficacy will tell you about the maximum response, maximum effect, or the maximum response. It is a maximum effect. You can either call it as effect or the response. It is a maximum response or the effect that will be produced at a given dose. What do you understand by the potency? So potency will give you an idea of the dose. It is the amount or the dose. So please remember, potency will tell you about the dose that is required to produce the maximal response. So dose, or it is also called as the amount of drug which is needed to produce the response, is nothing but the potency. So usually when you plot a graph, so this axis will going to determine the dose, and this axis will going to determine the response. That means efficacy is response and dose means it is the potency. So next, coming to the mydriatics. So which is the longest acting mydriatic? So I hope all of you can remember this. A very easy question that can be asked. So it is your atropine. Atropine is a very longer acting drug. It will act for 7 to 10 days, nearly around 7 to 10 days. So the shortest acting mydriatic will be your tropicamide. It is also a atropine derivative which acts for 10 to 16 hours. So next, coming to the cycloplegic agent of choice in children. So please remember, the cycloplegic agent of choice in case of children is your atropine. Because since children have high ciliary tone, so atropine can overcome this high ciliary tone. So that is why the atropine is drug of choice, or the agent of choice, or the cycloplegic agent of choice in case of the children's for any refractory error testing. So next, coming to the phocomelia. So phocomelia is a teratogenic effect. So please remember, teratogenic effect mainly produced by which drug? Phocomelia. So phocomelia is produced by a drug called as thalidomide, which was initially it was used as an anti-emetic drug in case of pregnancy. It was used as an anti-emetic drug in the pregnancy, in case of pregnancy. And it is also called by another name called, that is seal-like limb deformity. Next, we will move on to the examples for the zero order kinetic. So this has been asked frequently in your exams. This thing you should never forget. So the zero order kinetics example will be your, this can be remembered in the form of mnemonic, that is 0 watt bar. W stands for warfarin, and it can be of heparin also. Both are anticoagulant. And you have a alcohol, and you have a aspirin, and you have theophylline. Next, you have a tolbutamide, one of the anti-diabetic drug. And next is the phenytoin. So this will be the zero order kinetic example, that is W stands for the warfarin and the heparin, A stands for the alcohol, and one more A stands for the aspirin, and T stands for theophylline, T stands for tolbutamide, and the phenytoin. So next, moving on to so how do you calculate the dose in case of children? So what is the factor which will mainly determine the dose of the children? So please remember, dose of a children is calculated based on the body surface area. Of the children. It is also called as BSA. So next, coming to the drugs which can induce macrosomal enzymes. Can be written by a mnemonic called as GPRS cell phone. So all of you must have heard this. very useful mnemonic and easy to remember. G stands for what is G stands for? Griseofulvin, and P stands for phenytoin, and R stands for rifampicin or rifampin, and S stands for smoking, and C stands for carbamazepine, and the one more C stands for phenobarbital. So these are some of the examples you should remember under the drugs which can induce the microsomal enzymes. That is your griseofulvin, phenytoin, rifampicin, smoking, carbamazepine, and the phenobarbital. Most frequently asked question from this is, can we combine rifampicin with the oral contraceptive pills? Yes or no? Yes or no? So the correct answer is, you cannot combine. The answer is no. The reason being, it's an enzyme inducer. It will going to increase the metabolism of OCP, and concentration of OCP will come down, and it will be ineffective, leading to what it is called as contraceptive failure. Contraceptive failure. So next, moving on to the microsomal enzyme inhibitors. So this is also a very important topic that you need to remember. So it can be remembered as vitamin K cannot cause enzyme inhibition. So here V stands for valproate, verapamil. K stands for ketoconazole. C stands for cimetidine, antihistaminics. One more C stands for ciprofloxacin, and you have got the erythromycin, and I, you have got the isoniazid. So just to revise, so under the microsomal enzyme inhibitors, you have got valproate, verapamil, ketoconazole, cimetidine, ciprofloxacin, erythromycin, and INH. Here the one thing you should remember is, all the anti-epileptic drugs are what? All the anti-epileptic drugs are enzyme. They are enzyme inducers. So all are enzyme inducers except for valproate, that is sodium valproate. Sodium valproate will be the enzyme inhibitors. So next, coming to the very important topic that you should not miss in your exams. So whenever they ask about how to treat the weak acidic drug poisoning and weak basic drug poisoning, so please remember some of the acidic drug names also. They may ask the name and they can ask you to tell how to treat this poisonous conditions. So we have drugs like B stands for barbiturates, A stands for aspirin, D stands for diclofenac, M stands for methotrexate, and S stands for sulfonamide, and P stands for penicillin. So all these drugs comes under weak acidic drugs. So whenever there is a poisoning due to weak acidic drug, you need to go for what is called as alkalinization. Alkalinization. So what alkalinization? It is urinary alkalinization. Urinary alkalinization. So next is if there is a basic drug poisoning. So what are the basic drugs? We'll see here. M stands for it is your morphine. It is your morphine. A stands for amphetamine. One more A stands for the atropine. And S stands for scopolamine or iosin. And Q stands for quinine. So these drugs are weak basic drugs. Whenever there is a poisoning of weak basic drugs, what you need to do is you need to go for urinary acidification. So one should remember that the drug will be unionized. Unionized in which medium? Unionized in same pH, whereas drug will be ionized in case of opposite pH. That means the ionized means it is water soluble, and non-ionized means it is lipid soluble. So for alkalinization, so which are the drugs which can be used? You can use sodium bicarbonate, or you can use carbonic anhydrase inhibitors. The example will be your acetazolamide. So for making a urine acidification, you can go with vitamin C, you can go with ascorbic acid, or you can go with the ammonium chloride for acidification of the urine. The same thing has been depicted here. So you can see that aspirin is a weak acidic drug in case of the aspirin poisoning. So aspirin poisoning, the pH will be acidic. So to increase the excretion of the weak acidic drug, you need to alkalinize the urine, so that the pH will be the alkaline here. So it can be done by alkalinization of the urine, can be done by sodium bicarbonate and the carbonic anhydrase inhibitors like acetazolamide. So thereby it increases the ionization in the water soluble form, and it will be removed. Next comes the amphetamine poisoning. Amphetamine, as we discussed, so one of the peculiarity that you should remember is all the basic drugs, they are ending with what they are ending with. Can you make out? INE. So INEs are nothing but the basic drug. You need to go for urinary acidification. So it can be done by vitamin C, ascorbic acid, and the ammonium chloride. Thereby the same thing will occur, that is, it gets ionized and it will be removed because of the water compound. So what happens if a pH is equal to a constant, that is pKa? So please remember 50% of the drug will be in ionized form if pH is equal to pKa, and another 50% will be in a unionized form. So this will be the fate whenever the pH is equal to pKa. 50% of the ionized forms of the drug and 50% of the unionized forms of the drug will be present whenever the pH is equal to pKa. So dialysis is not effective in. So which are the conditions where dialysis will not be effective? So you can avoid unnecessary dialysis in such treatment, or the individuals who are taking the drug. So the examples will be it is the amphetamine, you have verapamil, you have opioid group of drugs and OP compounds, and you have got the imipramine, that is tricyclic antidepressants. Then you have got digitalis, and you have got diazepam, diazepam and the digitalis. Diazepam, you have got the another antidote, that is the flumazanil, and here in the opioid antagonist you have also got the naloxone as the antidote of choice or opioid receptor antagonist, and flumazanil will be, this is the opioid receptor antagonist, whereas flumazanil is a benzodiazepine receptor blockers, or it is the antagonist. So next, moving on to the another next very important line, that is all AC inhibitors are prodrug except for, you need to remember two drug names, that is CL. One is the lisinopril and another is the captopril. So all are prodrug except for the captopril and lisinopril, which are active by themselves. So next, coming to the loading dose. So why we need to give a loading dose? Loading dose is given to saturate the tissue stores, to accommodate or completely occupy the tissue stores. You need to give the loading dose so that when the tissue stores are attained, you can reach the steady state concentration easily. So, and also these LD drugs will have a large volume of distribution, like the drugs which are having a large volume of distribution. One such good example will be your chloroquine. So chloroquine will be the example for the drug which is having the larger volume of distribution. So loading dose will mainly depends on the volume of distribution. So please remember, it depends on the volume of drug distribution. So it can also be represented by VD. So what does MD stands for? MD stands for the maintenance dose. The maintenance dose depends on the clearance. So how do you formulate the plasma T-off from the volume of distribution, the clearance? It is the 0.693 into multiplied by volume of distribution divided by the clearance. Next, we have a first order kinetics and zero order kinetics. A very important, again, this has been asked n number of times. So to make it easy to understand, so let us say F stands for, it is a fraction of the drug. It is a fraction of the drug that gets excreted in a unit time. So this is nothing but it is the amount of drug which is getting eliminated in a unit time. It is the first generation, is the fraction. So how we can remember? First generation, it is a factor, fraction, and amount somewhat it looks like amount. Okay. So next, the rate of elimination is proportional to the plasma concentration. Rate of elimination is not proportional. It is not proportional. So what happens to the clearance and the T-off? So since the rate of elimination being proportional to the plasma concentration or the drug which is being administered, the clearance and to T-off will remain same. So there will be no change in the clearance as well as T-off even if you increase the dose of a drug which is following the first order kinetics. So what happens in case of zero order kinetic? Clearance will going to decrease and T-off will going to increase. So nothing but the clearance will be inversely proportional to the plasma concentration. So if the plasma concentration goes on increasing, clearance will goes on decreasing, and again what happens is it increases the plasma T-off. So first order kinetic, the clearance will be proportional to the plasma concentration. As you increase the plasma concentration, clearance will also going to increase. So there will be no side effects or toxicity associated with drugs following first order kinetic, and the drugs which are following zero order kinetic will be little bit headache because of their early saturation of the enzymes for metabolism. So coming to the therapeutic index, the drug which is having a low therapeutic index requires a therapeutic drug monitoring so that we can easily as well as safely can prevent the adverse drug reaction related to the drugs which are having the low therapeutic index. So it can be remembered as drug possess low therapeutic index. The example will be here aminoglycosides, and next you have a digitalis, next you have phenytoin, next you have a lithium, next you have tricyclic antidepressants, and it is the immunosuppressants. So these are the drugs which really requires a therapeutic drug monitoring. Therefore, we can prevent the adverse drug reactions. So next, coming to a very important concept that has been asked again n number of times in your example in your exams. So let us understand. Let us draw here two lines perpendicular. So this x-axis represents the log dose, and y-axis is the one which represents the Vmax or the response. Whenever you plot a graph of drug A, it is a sigmoidal curve, and when you give a drug B, it is a sigmoidal curve. So curve what we obtain from the log dose will be your sigmoidal curve. So when you give a competitive antagonist, to overcome the competitive antagonist, what you need to do is you need to increase the dose of the drug to produce the similar response. So competitive means they are the reversible in nature. If you increase the dose of the agonist, it can surmount or it can overcome the block produced by the competitive antagonist. So here this will be the competitive antagonist. So there is a parallel right shift of the graph. So this indicates that the efficacy, the height will tells you about the efficacy and the base will tell you about the dose. So what is happening here? The efficacy is same, but the dose of drug A and drug B is different. So what is happening? The efficacy is same with respect to drug A and drug B, but the potency of drug B is potency of drug A is more compared to drug B. So drug B is less potent when compared to the drug A. On the non-competitive antagonism, what will happen is when you give a non-competitive antagonist, so there will be downward shift of the graph. This is irreversible in nature. Even if you increase the dose of the drug, the response will not going to touch this level. Response will come down. So it is called as downward shift. So what will happen to the efficacy? Efficacy has reduced, and what happens to the potency? Potency can remain same or it will going to decrease once you increase the dose of the drug. So apart from that, you should also remember this line diagram given beautifully by the Lineweaver-Burke plot. So what it tells you about? It will going to help in understanding what is the Km with respect to the drug A, that is a competitive antagonism, and the drug B, which is a non-competitive antagonism. Both Km and Vmax can be easily remembered by this graph. So here x-axis will going to represent 1 by Km and y-axis will going to represent the 1 by Vmax. So let us make a general statement that whichever the line which is closer to the central area will have a increased effect with respect to their parameter. If it is further away from this central point, their factors will going to decrease or reduce. So with this keeping in mind, what is the response with respect to the center, whether it is farther away from the center or whether it's nearer to the center, will decide whether this parameter is going to increase or decrease the antagonism. So in case of competitive antagonism, so this is the competitive antagonism, there is an intercept in the y-axis with respect to the agonist y-axis. So what we were telling, y-axis will tell you about the Vmax. So it is on the same as that of the agonist. That means the Vmax will remain same or unchanged. What is happening to the line which is line which is coming onto the x-axis or line which is approaching towards the x-axis. So it is nearer to the 0, nearer to the central point. Therefore, the Km will increase. Whereas B drug is the non-competitive antagonism. Here you can see it is making an intersection on the y-axis, but it is farther away from the 0. But what is happening to the potency on the 1 by Km? So it is attaching to the same point where the agonist was attaching to the x-axis. That means to say, since it is farther away, Vmax will be reduced, but the Km will remain constant or the same. So this you should remember, very easy and very frequently asked. And next comes the ion channels. So under this you need to remember some of the examples. So what are the examples which you need to remember? So please remember, so we have a ion channels. The example will be your nicotine receptor, GABA, glutamate, NMDA, AMPA, as well as the 5-HT, that is serotonin receptor. The most frequently asked is the tyrosine kinase. So it is exhibited by the growth factor, insulin, and insulin-like growth factors 1. And we have a JAK-STAT enzyme receptors. So this will be followed by the prolactin, growth hormone, interleukins, and the cytokines. So in other words, they are also called as enzymatic receptor. The mnemonic will be your PIG. So P stands for prolactin, I stands for insulin, and G stands for the growth hormone. That is the enzymatic receptor, insulin, growth hormone, and the P stands for the prolactin, insulin, and the growth hormone. So under nuclear receptor, very important again, we have a nucleus and cytoplasmic. And the cytosolic or cytoplasmic, we have mainly 4 examples to remember. One is the vitamin D, mineralocorticoids, glucocorticoids, and androgen receptors. Whereas in the nucleus, you have got the T3, T4, we have vitamin A, estrogen and progesterone, as well as the paroxysmal proliferator activated receptor, that is PPAR. So what will be the fastest acting receptors? The fastest acting will be your ion channels. So this will be your fastest acting. So the fastest acting is your ion channels, and the slowest will be with respect to the nucleus or the nuclear receptors. So next, coming to the very important line diagram. So again, this will going to tell you about the potency or the dose, and this will going to tell you about the response. So this will be indicated as drug A, drug B, drug C, and drug D. So what will happen to the intrinsic activity? So intrinsic activity is nothing but intrinsic activity will tell you about the ability to activate the receptor. Affinity means the ability to bind to the receptor, whereas intrinsic activity means it is the ability to activate the receptor. So intrinsic activity will be 1 for the agonist. This is the agonist, and intrinsic activity of B will be around 0 to 1. So it is called as partial agonist. And C, this is the line. So intrinsic activity, this one will be your 0 to 1, and this will be the 0. So this will be your antagonist, and you have a D graph, that is intrinsic activity will be -1. So this is the representation of the inverse agonist. So let us revise. The topmost graph will be your agonist, which has got maximum intrinsic activity of 1, and next is the submaximal response will be there with respect to the partial agonist. The intrinsic activity will be between 0 to 1, whereas the intrinsic activity will be 0 for the antagonist, and intrinsic activity is -1 for the inverse agonist. So what is beta carbolin? Beta carbolin is an inverse agonist. At the benzodiazepine receptors. It's the inverse agonist of the benzodiazepine receptors. Very important. So next, let us see which are all the drugs which undergoes acetylation process. It's one of the biotransformation which occurs with the specific drugs. So acetylation with seen with some of the drugs like ship drugs, that is the sulfonamide, H for hydralazine, and I for isoniazid, and P for procainamide. So all this drug will going to cause SLE-like symptoms, that is systematic lupus erythematosus. Again, very important. So coming to the malignant hyperthermia, it mainly occurs due to the defective in the ryanodine receptor, defect in the RYR1 receptors. So basically these will be caused by two drugs, that is they are called as the halothane. Halothane can cause malignant hyperthermia, and succinylcholine can cause malignant hyperthermia. So what will be the drug of choice here? The drug of choice for the malignant hyperthermia are dantrolene sodium. Dantrolene sodium will be your drug of choice. This will be the drug of choice in case of malignant hyperthermia. So what do you understand by the orphan drug? Orphan drug means they are the drugs which are prepared for the rare diseases where if the company spends on these products, they will not get a profit. So government has made some subsidies that will be given to the manufacturers to the benefit of the patient. So one such example is the deferiprone. Deferiprone is a iron chelator. Basically it is used in case of iron poisoning due to thalassemia. And acetylcysteine is antidote for paracetamol poisoning, that you should remember. So again, we have got the Schedule H. Schedule H means there should be a prescription. Without prescription, you cannot buy a medication. So no buy of tablets. So Schedule G means it is a guideline. Or the measure to be followed by certain drugs. And symbol NX stands for narcotic drugs. Whenever you prescribe narcotic drugs, like example is the clonazepam, so you'll write it as a NRX. XRX means there is no significant importance, and they are not used generally. They're used for the drugs like Tamiflu, that is oseltamivir, etc. So the best quality of evidence will be seen with which of the following studies? Best quality of evidence. The best quality of evidence will be seen with the meta-analysis. This will be the first meta-analysis. This will be the second, and goes on decreasing. So the least evidence will be found with the case control study. Maximum evidence will be seen with the meta-analysis and the systematic reviews. Then comes the RCT, randomized control trials, non-randomized control trials, and the cohort studies. If they ask in your exam, so please remember the lowest order of the evidence is with respect to the case reports or case series, whereas in case of the highest level of evidence or the quality can be maintained in case of the meta-analysis and the systematic reviews. Next comes what is the importance of the plasma protein binding. So please remember the importance of plasma protein binding is, so this will going to increase the duration of action. On the other hand, it will going to cause distribution, and since plasma protein binding increase the duration of action, what will happen to the volume of distribution? Volume of distribution will decrease because almost all the drug will be bound to the plasma protein. So displacement can lead to adverse effects of the other drugs, and dialysis is not effective in some of the drugs which are having high plasma protein binding capacity like digoxin, amphetamine, opioid, etc. Next, we have a graph. So they can give this graph in your exams and they ask which is the first order kinetic and the zero order kinetic. So first order kinetic is also called as the linear kinetic. This is the first order. First order, they are also called as linear kinetics. Linear kinetics. So this will be the first order and this will be your zero order. Zero order kinetics. Zero order kinetics. So next, very important that you should remember is the rifampicin. So rifampicin can cause a therapeutic failure. So therapeutic failure when it is given along with the oral contraceptive pill. So what could be the reason? The reason being is a potent, it is a potent enzyme. So what is the rifampicin? We talked about GPRS cell phone. So here comes the R stands for rifampicin. So it is a potent enzyme inducer. Thereby what happens to the oral contraceptive pills? Concentration will reduce due to the increase in the metabolism. So metabolism leading to decreased concentration, leading to a therapeutic failure of the oral contraceptive pills. So whenever you give such drugs like rifampicin and all, you may ask the patient to follow the barrier method instead of the medications. So next comes they can give this kind of graph also. What does this represent? So what is A, what is B, and what is C? So A represents the Tmax, C represents the Cmax, and this B represents the area under the curve. Area under the curve will tell you about the extent of absorption. So please remember extent of absorption, not the elimination of extent of absorption. And next we have a Tmax. It is the peak time at which it reaches the concentration, or it is also called as rate of absorption, rate of drug absorption. Cmax will tell you about the maximum concentration that has been achieved here. So which will be the fastest acting receptors? Again, the revision. So it is your ion channel. Receptors. Which will be the slowest? That will be your nuclear receptors. So again, they may give this kind of graph telling that to calculate the therapeutic index. So this point will be your ED50 and this point will be your LD50. So as we discussed earlier, it is represented in the form of tile. So that is LD50 divided by ED50. So what will happen? So there is a 200 milligrams and 10 milligrams. So therapeutic index is 20 milligrams for a particular group of drug. So sometimes they are going to give a diagram like this and they are going to ask the potency and efficacy of a drug. So let us draw a diagram here for you. Okay, this one, and this one, and this one. Let us take a namings for each one of them. This is drug A, drug B, drug C, and the drug D. So this will be the x-axis and y-axis. This will be the dose and this will be the response. So which is more efficacy and potency wise? So A, when compared with A and B, let us write the efficacy here. With respect to the efficacy and the potency, when you compare A and B, what will happen? A is more efficacious than drug B, but they are equal to potency. What will happen to A and C? So A is equal to C in efficacy, but A is more potent than drug C. So what will happen to the drug A and drug D? Again, the drug A is more efficacious than drug D, and drug A is more potent than drug D. So when you compare B and D, what will happen? B is equally efficacious to D, and B is more potent than D. And what about B and C? B and C, B is having less efficacy when compared to C, but B is more potent than C. See, that you need to remember. So that's how you can go with the simple permutation and combination. If you take C and D, what will happen? C is more efficacious than D, and C will be more potent than drug D. So you need to monitor the graph levels. So if it moves further away, from the center, what will happen to the potency? Potency will reduce, means the dose is more, dose required is more. So the efficacy also, once you increase the height, what will happen? The efficacy will be more. So if it is going like this, efficacy will be less. Next, coming to the very important topics which can be asked in your exams, again a very important ones. So please remember, we have acidic drugs. Acidic drug will going to mainly bind to the albumin. Basic drug will bind to the alpha-1 acidic glycoprotein. So they're going to ask nitroglycerin why they are having rapid action. So nitroglycerins are given sublingually to avoid the first pass metabolism. Apart from that, so usually the drugs which will be given through sublingual route will be of non-ionized form, that is a lipid soluble form. They have very high lipid solubility, because of which they get rapidly absorbed without any first pass metabolism. So there are some drugs which you need to remember, very important with respect to the proton pump inhibitor and the clopidogrel, that is the antiplatelet agent. They both are the substrates for the CYP2C19. Thereby they are more prone for the drug interactions. So when we come to the metabolic reaction, that is the biotransformation, we have a phase 1 and phase 2. That is, the phase 1 is non-synthetic and phase 2 is the synthetic reactions. So basically biotransformation helps you to convert the drug into a water molecules, hydrophobic molecules, or the polar compounds, so that it can get easily excreted to the feces or the urine. The phase 1 reaction includes the oxidation, reduction, and hydrolysis. Apart from that, you have cyclization and dicyclization. So for the ease of remembering, you can remember only three: oxidation, reduction, and hydrolysis. The phase 3 is the one where the important reactions will take place. That is the once the compounds are formed in the phase 1, this will going to get combined with these compounds to get excreted in the urine. So they recommend glucuronidation, acetylation, methylation, sulfation, glycine conjugation, etc. So when do we reach a steady state? Steady state of plasma concentration is reached only after the 5 half-life. 5 half-life, very important. So what are the secondary messengers? We know secondary messengers, we have a cyclic AMP, cyclic GMP, inositol triphosphate, and diazyl glycerol. So this has been already asked in your exams. So next, coming to the very potential MCQ, that is a drug causing hemolysis in G6PD deficiency. So how we can remember easily is, let's start with the primaquine. So primaquine. So next is the quinine. Quinine sounds like chloroquine. Then comes the dapsone. So will come at the end. You have sulfonamide. You have N here, we have nitrofurantoin, nalidixic acid. Since it is acid, we have a acetyl salicylic acid, that is the aspirin, and we have a menadione. So these are the drugs which will cause hemolysis in case of individual with G6PD deficiency. So next, coming to the normal log dose response curve. What is the shape of the normal log dose response curve? So the curve will be of sigmoidal in shape, very important. So this has to be remembered, sigmoidal. And vitamin and essential medicines will have U-shaped dose response curve, whereas formaldehyde will have a J-shaped curve, and estrogen will have a inverted U-shaped curve. So vitamins will have a U shape, whereas estrogen will have an inverted U shape. So coming to the adverse drug reactions, how do you define the adverse drug reactions? Adverse drug reactions is nothing but something which is noxious and unintended effect that will be produced by the drug. So based on the severity and all, we classify the adverse drug reaction into 6 types. That is drug A, type A, type B, type C, type D, type E, and type F. So the word letter will going to give you the link or the idea to tell about what it is. So type A means augmented reaction pharmacological effect. Type B means bizarre effect or idiosyncratic reaction. Type C means the chronic effect. Type D means delayed effect. And type E means the end of treatment effects. And F is the failure of the therapy. So augmented means augmentation of the normal therapeutic response will be augmented. It is called as dose dependent, and it is predictable in nature. Dose dependent and predictable in nature. Example is the hypoglycemia caused by any of the anti-hyperglycemic drugs like sulfonylureas. So next we have a type B reaction, that is a bizarre reaction or idiosyncratic reaction, which are dose independent and they are not predictable. Dose independent and they are not predictable. So one such reaction is the penicillin causing allergic or hypersensitivity reactions. Then drug type C will be the chronic effect, that is a peptic ulcer due to the chronic NSAIDs or the corticosteroid use. So delayed effect will be the teratogenicity, which is caused by the thalidomide, that is the phocomelia. End of treatment effect, that is will be seen after withdrawal response to the morphine. And therapeutic failure due to the failure of the therapeutic responses. So next comes the schedule, again a very important slide which needs to be remembered. The C. Schedule C1 stands for biological and special products, whereas FF1 stands for vaccinations, the bacterial vaccines, and G stands for guidelines or medical supervision. Drug has to be labeled and it has to be it will be given in case of medical supervision. So mainly it is done for dangerous prescriptions where the patient guardian has to make a provision, or any of the healthcare profession individuals need to monitor as well as give a medical supervision or guidelines on the usage of the drug. H stands for it's a drug that must be sold by the retail only when prescription is produced by the registered medical practitioner. M stands for it's a good manufacturing practices. Schedule deals with the good manufacturing practices. P will tell you about the expiry period of the drug formulation, and W will tell you about the drug shall be marketed under generic name only, and X will tell you about the psychotropic drugs which require special license for manufacturing in Israel. X stands for psychotropic drugs, and Y stands for regulation and guidelines. So just to revert, C and C1 stands for biological products. F and F1 stands for bacterial vaccines. G stands for guidelines or under the supervision. H stands for retail only. It has to be procured. Drugs should be procured only on giving the prescription. So M stands for good manufacturing practices. P stands for expiry of date of drug formulation. W stands for rules regarding making a generic drugs only. X stands for psychotropic drugs, and Y stands for guidelines led on to do the clinical trials. So next come to the counterfeit drugs. So please remember, the counterfeit medications are nothing but they are the fake medications. They are basically the fake medications or the illegal drugs. And it can be of contaminated state. It can be of a wrong active ingredient. It can be of, there won't be of any ingredient at all. So contaminated, wrong ingredient, no active ingredient. Although active ingredient is there, there can be a wrong dose. So all this will falls under the false medications or the counterfeit drugs. So next, coming to the some of the very important information with respect to the routes of administration. So please remember, under the routes you have got the oral route has got high first pass metabolism, very important, and rectal route has got 50% of the first pass metabolism will be prevented. And one such example is diazepam, when it is given through rectal route in children to treat the febrile seizures, the diazepam will be the drug of choice. Next comes the subcutaneous injection. One such classical example is insulin. Intradermal BCG is the example. And coming to the sublingual route will prevent or it avoids the first pass metabolism, useful in case of emergencies. The example is in case of angina, we use nitroglycerin, isosorbate dinitrate. We have a clonidine and epinephrine in case of the hypertension. Inhalational route, we can use inhalation route is one of the route which has got quickest absorption. Please remember, it has got the it is one of the route, it is the route with quickest absorption. Reason being, the lungs has got the alveoli has got the larger surface area. So the example is salbutamol, ipratropium bromide, budesonide, and the nitrous oxide, which is general anesthetic. And which is the drug which has got quickest action? Quickest action. That is your IV. But the quickest action through absorption will be through a inhalational route. Then we have a transdermal route. Only the drugs which are highly lipid soluble is given the form of transdermal patches, where there will be constant release of the medications. The example is again the nitroglycerin, nicotine, fentanyl, and the iosine. So basically, this is used for what condition? This is used for angina, nicotine for smoking cessation, and fentanyl for pain relief, iosine for motion sickness. So you should also remember at what angle you need to give the injections. So please remember, the IM injection is given at 90 degree, followed by subcutaneous, which is 45 degree, and IV is 25 degree angulation, and intradermal is 10 to 15 degree angulation. So also remember, whenever there is a tubular secretion takes place, what are the importance of the tubular secretion? So to increase the penicillin concentration and penicillin action, you give a proban acid. What is proban acid? Proban acid is a uricosuric agent which is given to treat the chronic gout. So when you give a proban acid, both proban acid and penicillin will going to compete for the same transporter which is present in the nephron. Thereby it decreases the elimination of the penicillin, and penicillin concentration will go on increasing in the plasma. So which are the drugs which are excreted through saliva? We have drugs like lithium, potassium iodide, and the rifampicin. Next comes the pharmacovigilance, very important. So pharmacovigilance, by definition, it is called as DAUP. It is a science and activity that deals with the 4 components. That is the detection, assessment, understanding, and prevention. So it has got 4 components: DAUP, that is detection, assessment, understanding, and prevention of what is called as adverse drug reactions or adverse effects. Adverse drug reactions are the adverse effects. So what is the causality scale which can be used? We can use Naranjo scale is there, WHO scale is there, etc. So software which is used to send the ADR report is called as VGFlow. CDSU is our center where it monitors the national level monitoring center. So that is the Drug Controller General of India. That is the Central Drug Standard Control Organization. UMC stands for Uppsala Monitoring Center. It is located in the Sweden. Whereas CDSCO is located in the Ghaziabad in the Delhi. The next we have a very important thing you should remember. What are the drug effects? So drug effects, you should remember, there can be of these 6 effects. So please remember, we have additive effect whenever the drug A and drug B is added together. So it adds up. 2 plus 2 is the 4. Aspirin and paracetamol analgesic action will add up. Synergistic effect means the effect of drug A and drug B combined together is more than that of the response of the individual drugs. So 2 plus 2 will be more than 4. 2 plus 2 will be more than 4. One such example is the antiplatelet agent like aspirin when given along with the clopidogrel. So clopidogrel will going to enhance the activity of the aspirin. So potentiation. So one drug will going to increase the action of the other drug. Here one such example is, though one drug doesn't have any activity, so that drug will going to enhance the activity of the other drug. So here the same thing will occur. The combined effect will be more than the individual effects. So carbidopa with levodopa. So carbidopa 0 plus 2 is equal to more than 2. So even though the carbidopa doesn't have any role in the Parkinsonism, so carbidopa will prevent the peripheral degradation of the levodopa, thereby it increases the effect of the levodopa. So that is called as carbidopa potentiating the effect of levodopa. So antagonistic effect, so drug A plus B combination is less than individual responses. 2 plus 2 will be less than 4. That is the ethanol, which is the antidote for methanol toxicity. So permissive action, very very important. Permissive action means a presence of a particular thing has to be present for action of the other product. That means here the cortisol will have permissive action, corticosteroids will have a permissive action. That means the presence of cortisol or the corticosteroid is a must for the catecholamine action. Catecholamine actions like rise in blood pressure, vasoconstriction, etc. So corticosteroids has to be there. So that's why corticosteroid, they have got permissive effect. Only in presence of the corticosteroid, catecholamine can produce the effect. So tachyphylaxis means what? So tachyphylaxis can be given in the form of this graph. So please remember this graph. Whenever you give a drug at quick interval of time, at quick succession, what will happen? The response immediately decreases. Tachy means fast. Prolaxis means it is the fast. Prolaxis means protection. So fast protection. So because of the decrease in the enzymes, or it mainly due to the decrease in the receptor, that means to say there is a down regulation of receptors, or it can be due to desensitization of receptors, which will lead to tachyphylaxis. Tachyphylaxis usually seen with the indirectly acting symptomatic agents like the xylometazoline and also like the tyramine. Example is tyramine, ephedrine, nicotine, etc. So these are the things which you need to remember from general pharmacology. So we have covered almost all the very important topics from general pharmacology. So hope this will going to help you in terms of revising the general pharmacology, so that you can get a good marks, as well as you will have a concept so that you can clear whichever the way the question comes in your exams. And one must remember that for anything to achieve, you need to have a consistency at daily practice. You remain consistency. So at least if you are not able to read a 10 page, you at least read a 1 page. In place of reading 50 pages, you read 20 pages. So the main thing is to maintain the consistency at doing a same thing same day as well as on the other days. So doing a particular thing every day for a longer period will give you a wonderful results. And maintain a cool environment, do not get tensed. Even other students will be having the same tension as you, so do not get your mood disturbed by any stress or any other matters. Like, don't compare with your friends, don't compare your scores with others. Even though if you are scored less in your some of the grand test or class tests, definitely if you are thorough with your concept, if you do a revision properly, you're going to fetch more marks than the other students. So, and you need to be confident about yourself. that I'm going to achieve something good. So that you need to do some hard work. So all the best. Thank you.